Fantastic. So opening the floor now to any questions.
I have a difficult question for the panel. One which we actually at another meeting began to talk about. We know from the vision nomogram that the correlation coefficient for that nomogram for OS is 0.73 with PSMA imaging included. And we know that the correlation coefficient of the vision nomogram is 0.73 without any imaging included, which sort of means that in those advanced patients, just how you're doing in terms of your disease state, like do you have functional marrow, what's your tumor burden, counts more in patient selection in terms of predicting survival than the imaging does, because it's about the same with or without the imaging. So what are we really doing by using PSMA to select for patients? And say for the ctDNA data that you presented that really is predictive, are we really using any criteria with PSMA other than just saying these are better patients globally, prognostically, than they are without the PSMA findings? Just really identifying patients who respond to therapy as opposed to just patients who don't.
I might take that. Mike, you and I are on the same team here, so this might be something that I would say in private during our little one-on-one sessions or other sessions. I'm not certain that we've utilized the scans to their best ability. We still have information, and we didn't even include the TTV, the total tumor volume, which is one of the parameters. We didn't have good measures of heterogeneity. I think those both may be contributory. Now, to your point about mentioning the ctDNA, within those nomograms, there was no integration of the genetics at all, which is yet another reason that we could be optimistic for improvement. So that 0.73 AUC is really not an optimized. You use the clinical criteria, the SUV mean, and a little bit more, but there's opportunity for additional analyses that I think will improve us. But that's just a personal opinion. I think.
Good point.
I think Louise has got another opinion, perhaps, or.
No, I don't have another opinion so much, but I guess it comes down to why are we giving the therapy? We've got these patients, so you're post 2 lines of chemotherapy, your hemoglobin's very low, you're about to go into marrow failure, you've got severe pain, you're on opiates, and you're desperate to live. Now, of course, your predictive nomogram is going to look appalling. Are you going to choose not to treat that patient? And then if you are going to choose to treat that patient and your PSMA PET shows absolutely no uptake at all and PSMA negative disease, are you going to help that patient by giving them a couple of doses of something that will be totally futile when you could have actually not had an opportunity lost by giving them something that they may have benefited from? They could have gone on to a phase 1 trial. They could have gone on to cabazitaxel if they haven't had it before. So, I guess, sure, in the nomograms, it doesn't look fantastic because prognostic, whether you're anemic or not, is a very powerful prognostic indicator, right? So trying to overcome that with imaging, I think it's beside the point in a way for me.
Good point.
I would say I can't agree more. And I think that was one of the main of my talk, to say what we have for now, we have only prognostic biomarkers. They should not influence our decision-making process and defer patients from getting Pluvicto. When we do have a predictive biomarker for OS, that we can discuss different. But now I think these biomarkers maybe can use to intensify the treatment, right? Maybe a low PSMA can go to a doublet or a triplet versus PSMA therapy alone.
Great. Thanks so much for the thoughtful responses.
Yeah, there was a lot of data presented on prognostic predictive biomarkers, so it can get a bit confusing. So Oliver, you highlighted the prognostic but not predictive biomarker of SUV mean greater than 10. And then the following slide you have ctDNA, and you said it was predictive. But the y-axis was different between the 2 slides, because the first slide was OS, and then the ctDNA was PFS. And in fact, I think Andre's slide highlighted that actually, if we look at SUV mean over 10 for PFS, it's strongly predictive as well. So there's just a nuance there. I'm just wondering what you think about that. And do you think ctDNA will be a predictive biomarker for overall survival?
Yeah, thank you, Michael, and very good point. I was trying to be a little bit of the provocateur with the ctDNA because it wasn't shown before. And when I first saw it at ASCO last year, Ed Kwan was presenting the poster, I really stopped and paused because it was outstanding. To your point, the OS is pending, and I think that that'll go to Ed Kwan's lab now that the OS for the therapy has been presented for the final analysis, and that'll be a publication that your group will present, and then you'll tell me what you found. The importance of what you pointed out is very clear. I wanted to perhaps be a little bit of the provocateur, but let's wait and see.
Thank you.
To Dr. Sullivan. You have told about the MR imaging after PSMA imaging, while the PSMA uptake was decreased or have no PSMA uptake. So why or when we need to have MR imaging instead of, for example, FDG PET-CT in these situations, you know?
Yeah, I mean, the point I was really making was some of the information we need from the imaging is whether there are discordant lesions. The classic way has been PSMA PET negative, FDG PET positive. That's one way of seeing it, but MR can do the same thing. I was just presenting it really in that way to sort of to highlight the discordant lesion. I wasn't really suggesting that whole body MRI was the way to find that out, only that it can contribute to that information. But I think FDG PET is obviously the standard approach to seeing discordant lesions and perhaps tells us something different about the nature of the prostate cancer, the phenotype. I think MRI can do the same thing, but I think it's more practical probably with FDG PET, realistically.
Thank you.
Sophie.
So, Oliver, I don't want to block your enthusiasm about this predictive marker, the ctDNA, but the numbers were really small. And I just think, like since all of you are doing a lot of academic trials with lutetium PSMA, it would be really worth probably to work together with Alex. I think also about Stabit and everything, we have so many that we try to collect ctDNA and try to confirm it and validate it, because otherwise, you will always be in that situation that your groups are so small.
Well, as mentioned, the therapy group will do the OS analysis with Alex and Ed Kwan. And so that data will come within the context of that beautiful randomized trial. But I agree completely, Silke, that the subsets are small. There is a little bit of additional unpublished data from Mayo that would similarly suggest that this is a good analysis to pursue. But as you pointed out, additional verification, larger subsets, additional trials, all important.
I have to say, from Alex's point of view, he is collecting quite a lot of data from a lot of different trials, and he's analysing it in exactly the same way. And so certainly within the ANZAP cohort, a lot of the trials will have ctDNA. They'll have multi-time point ctDNA, screening ctDNA. So I think in the next 2 years, quite a lot of data will come out.
Thank you. I want to congratulate Stacey for generating these kind patient-centered radiology and histopathology reports. Are these generated by pathologists and radiologists or by the urologist in the patient's language?
All of the above, and with patients, most importantly. So I showed you step one of our process, which was asking the expert panelists what needs to be included. Step 2, and most importantly, is next to convene with your patients to discuss how best to share these findings. So that is what we're planning to do in New York, and would be great to see happening in other contexts where there's rapidly expanding use of PSMA PET, to talk to the patients about some of the definitions were proposed. Is this clear? Is there other information that you would want to see? And then tailor the report from there. And then I think the model that they showed of then doing a randomized trial with your own patients to see whether those who receive one of these augmented reports actually, express, more satisfaction and better understanding.
But the MRI reports and the histopathology reports are already standardized and validated?
Yes, so those have been, at least in their context, So, for instance, that group that published from Canada, so I think you could certainly adopt a similar report to their model, and, make sure to just obtain feedback from, your patient population.
Are they available on the AUA website for everybody?
I mean, some of these are available in their publications. I don't know of any of them being available on society websites, and that might be actually, I think that's a great suggestion. I think this could be an important initiative for those of you who are involved in, imaging or pathology societies to consider, sharing potential formats that people could use for this.
Thank you. And I want to congratulate Nick for his Man project. I've heard about it through Masood Mughal before, and it's really thoughtful project to take the service, prostate cancer service, to the community. But I can see from your description that patients still need a GP, registered GP, and an invitation to attend these appointments, which means it's not a walk-in service. Patients just can't walk into your van and have a PSA test. So I'm just thinking about patients without a home or an address, how they will access this service. And the really deprived men who are in institutions like the handicapped, learning difficulties, men in prison, for example. Are there any solutions for these men?
Yeah, thank you, and all really, really good points. So we did various approaches to getting, in order to access the van, you had to have an NHS number. It didn't require, which means you are intrinsically registered to a GP. You may not know who your GP is, but you will have one. So we explored various ways of getting people in the van, and they all worked, and they all got different people. So we went through community groups, we went through church groups, we went through council groups that sort of had outreach things. So like Brent Council, very high black population, they had a whole lot of black community groups, and in Brent we got over 50% of the men coming through the van were black. And one of the things we did there, for example, was we produced a whole load of videos voiced by different ethnic groups. So, and for example, we did Black African and Black Caribbean separately, the same content, just different accents and people speaking, explaining why it was important, and we got very high uptake rates. And so things like had we been able to run for longer, we had plans to go through both long-term mental institution patients and through prisons for exactly the reasons that you say. We know these groups have poorer outcomes. We didn't get as far as doing it. But we also did things like parked it up in IKEA Croydon with a great big barcode on the side. The reason we didn't, and you could just scan it and book an appointment, the reason we didn't do walk-ins is that it takes 15 minutes, so you'd very rapidly have a queue, and we had no place to make them wait or whatever. So if people did pop their head in the door and asked the administrator, how do I make an appointment, they would be assisted to make one, and they'd get a range of appointments, but we couldn't do walk-ins because the time just wasn't efficient.
A good thought-provoking project.
Yeah.
Thank you.
Yeah. Actually, I just had a comment on your stuff. It struck me, if you've ever looked at a sort of electrophysiology report or a sort of cardiology catheterization report, it's incomprehensible unless you're a cardiologist or a neurophysiologist or whatever. Why don't we just write all our reports in English and not in jargon and acronyms? Because there was no information lost in those reports, was there?
Right, absolutely.
Yeah.
Actually, I had a question on the incidental findings. So this is something that's very difficult for an imager. So you see the thyroid nodule, But you don't want to make a big thing about it. At the same time, you can't not call it, or you can't see what you have, you can't unsee what you've seen, but you don't want to send a patient down a rabbit hole of seeing multiple clinicians because they've got these incidental findings. And at the same time, do we have the expertise to say this is definitely something that needs to be looked at, definitely something that doesn't need to be looked at? And I think it is very irritating for a urologist to have multiple things in a report. So how do you think we should, sort of adjudicate that as images, Stacey?
I mean, I think the ideal scenario, we do see reports where it says, let's say like there's a cystic pancreatic lesion and, according to, XYZ criteria, like this is the interval of imaging that this person should have. So at least when I see this, even though I'm thinking, oh God, like the pancreas, that's above the belt, what am I going to do? But it says right there what the plans are. So, or you refer to GI. But I think the problem with these is we're just seeing, a median of 4, but up to 17 per patient. So now, the hot potato has been passed from, the radiology department to me, the urologist, who now has to, refer somebody to all different places. I mean, and the patient end up asking me. I mean, actually, as we're sitting up here, it's already, normal business hours in New York. I'm sure that by the time I get off this stage, I'll have epic MyChart messages from patients who have already read their reports today and are wondering, should I be worried about this nodule in organ X? And I'm like, I'm not sure either, but we're going to figure this out. So I think this problem needs more attention, is the bottom line, because I have not seen a lot written about that, and I think this puts it may be difficult for you if it's outside of your major area of expertise. Certainly it's difficult for us as the referring physician, and can't imagine what that must be like to be the patient and to see all these things.
It's a really important question because, people who have prostate cancer imaging, they're older, they have all these accretions that you just see, right? You see their history, their life on the images. So we really need to balance what we call. Any other questions? So there is one question online. Dr. Sato, with the growing body of evidence supporting PSMA RLT, particularly from VISION and SPLASH, what do you see as the main obstacles to integrating this treatment earlier in the MCRPC therapeutic algorithm? And do you believe that PSMA PET heterogeneity and patient selection remain the biggest challenges? Or do you see other clinical, regulatory or access-related factors as more pressing?
So it's likely that PSMA-4 will be FDA approved within the context of the taxane-naive metastatic CRPC space with VISION criteria for the PSMA PET scan reading. A little bit of a mouthful, but I think it's likely to occur. That will not occur in Europe. It's an RPFS issue. The RPFS is not an accepted endpoint within the European environment. So what will it take to be able to bring things earlier? I think in the end, it'll be overall survival and quality of life that'll be more acceptable to the Europeans. Unfortunately, that may mean that the trials will not have crossover. One of the confounding variables in the PSMA-4 trial was the fact that 84% of the patients eligible for crossover actually did. Now, that's only 57% of the intent to treat patients. However, remember that some of the intent to treat patients never progressed because they just did remarkably well on their second hormones. So it's a subset of subset, and you have to get down to the analytics. How do we move forward? I think it's overall survival and quality of life, more so than the RPFS. I think we're going to have to potentially do some new trials that will avoid the crossover, but then we face yet another issue. I heard Splash mentioned that's a whole other issue. I won't go there. We have Eclipse coming, and Eclipse might have some provocative data, but the PSMA 617 lutetium is got a high royalty burden. And from a financial perspective, when you begin to look at the royalty burden and the duration of the patents, it's likely that there will need to be new agents brought to the market in order to extend the patent life for the economic productivity that the investors require. So hold on to your seats. New agents, new trials are going to come, some potentially with alphas, some potentially with betas. And remember, there are things out there such as terbium-161, which are pretty provocative, not just lutetium. Anyway, Could talk about that for a long time, but I'll stop there.
And just a final comment online on Joe Sullivan's presentation from a patient. Thank you for the strong focus on what matters to a patient.